Hey guys, welcome to the second video of the Internal Medicine Residency series dedicated to interns. Today is your second day of your internal medicine residency as an intern. It's 4 p.m. and you're ready to go home. You're not on call, you think this is the end of the day and you're ready to go home. However, your senior calls you up and gives you an admission. And the case goes like this. A 55-year-old male with a past medical history of hypertension, DM, chronic alcohol abuse, ex-IV drug user on a methadone program presents with complaints of worsening shortness of breath on exertion. He claims to be able to walk at least 5 blocks before, but now he gets short of breath on walking 1 block. It is also associated with leg swelling. He reports to be using more pillows than usual and has recently gone up on his pants size. His symptoms worsened to a point that he's very short of breath that he called EMS and came to the hospital. Alright, so based on this case that is presented to you, obviously you're going to get much more in-depth history taking, which I'm not going to go into. But based on the history that is given to you so far, the patient is predominantly complaining of exertional dyspnea, using more pillows when he goes to sleep, which is known as orthopnea. He's complaining of leg swelling bilaterally. This is known as bilateral pitting pedal edema. And he's also complaining that his pant size has increased recently, which is suggestive of ascites. Either way, when you bring all these factors together, obviously you're thinking of what condition at this point of time. I'm pretty sure this case is pretty straightforward for you to think of heart failure. However, you must also think of all other failures that can give rise to the similar symptoms. Predominantly, you're talking about the kidney failure and liver failure, which should be in the back of your mind. Alright, so now we're going to go into the physical examination, which again, as I mentioned before, it is the most crucial part, guys. You have to do a very thorough physical examination, as it's going to give you all the clues you need for the actual diagnosis. So this patient on physical examination, vital signs, you have blood pressure 160/90, heart rate of 108, respiratory rate of 28, telling you that the patient is in some form of respiratory distress. Temperature is 99 degrees Fahrenheit. On general physical examination on this patient's appearance, he seems to be in respiratory distress. He's having a lot of nasal flaring. He's holding himself in a tripod pattern. He's breathing like this. He's not able to lie down flat. That's exactly what you're going to be seeing in this patient. On head, ear, nose and throat, you're going to see the patient has a elevated JVD, a jugular venous distension is present. And cardiovascular system, S1, S2 heard and S3 is heard. However, the patient does not have any rubs, gallops or murmurs. Alright, and respiratory system, the patient's got bilateral crackles heard all the way up to the level of his scapula. And abdominal examination, the patient's got an distended abdomen, and on percussion it is dull, essentially indicating that there is fluid within the guy's abdomen. And apart from that, you also have a palpable liver. Now, hepatomegaly is also present in this patient. And finally, lower extremities, the guy's got bilateral pitting pedal edema 4+ extending all the way up to his thighs. And the patient, when you look at him, is actually seated in more of an upright position and he's appearing short of breath. Now, based on this physical examination, clearly you see the patient and you think, alright, so this is most likely heart failure. But the guy does not have a history of heart failure. Does he have risk factors? Sure he does. He has a history of hypertension. He has a history of diabetes. He has a history of coronary artery disease, and he's got 2 stents in the past. He's also an ex-IV drug user and he used to consume a lot of alcohol. So he has a ton of risk factors for heart failure. However, he did not have a history of heart failure in the past. So this is a case of new onset heart failure. However, I told you, do not disregard the fact that this could be liver failure or kidney failure as well. The way you're going to be able to express these things is by doing certain lab tests and orders, which is very crucial as it's for you as an intern. So we're done with the history and physical examination. Now it's time for you to place your orders. Alright, so what kind of lab tests are you going to need in this patient? So this patient is going to require CBC because you want to look at the WBC count as well as the hemoglobin. Alright, now the thing is, because the patient is having shortness of breath, maybe he has an infection going on, right? So you want to see the WBC count, which can actually kind of suggest any form of infection. You want to look at the patient's hemoglobin, because maybe the patient is anemic, which is predisposing the patient to now have some form of myocardial ischemia. So it's crucial for you to actually know what the hemoglobin is as well. CMP, now this is a very important lab test you must get. Reason is you want to look at the BUN and creatinine. As I said before, when somebody comes with fluid overload, one of the other differentials is in fact a patient who has renal failure. Maybe the patient has chronic kidney disease. However, maybe the patient does not have a chronic kidney disease, but because the patient is having heart failure, because the heart is not pumping well enough and therefore you have less perfusion to the kidneys, this could result in an acute kidney injury as a result of the heart failure. It could be either one of them. So for that reason, you will require a creatinine level to be noted down. Then you also want to monitor the important electrolytes such as potassium, magnesium, calcium, and albumin is always a crucial component which comes with calcium. Reason is if the calcium is low, you have to correct it for the albumin. If the albumin is low, your calcium can be falsely decreased as well, and therefore you'll have to correct it. For that reason, you need to get an albumin level. Apart from that, you also need an AST, ALT, ALP, because I said before that the patient could be having liver failure, and as a result of the lack of proteins in your blood, your oncotic pressure could be low, which could be leading to all form of edema all over the body, and therefore you need to get that test as well. Finally, you also need to order a troponin as well as the BNP. Troponin is so important in this patient because the patient most likely is coming with a new onset heart failure, and one of the most common reasons for somebody getting an acute heart failure is in fact an acute MI. So troponin becomes very crucial here. Apart from that, you also want a BNP. Now BNP essentially is what is going to tell you the patient is in heart failure, and elevated BNP does not always mean the patient is in acute exacerbation of heart failure. Elevated BNP is suggestive of heart failure, or wherever there is fluid for whatever reason stretching out your right atrium could give you an elevated BNP. Alright, however, you will require a BNP level. A PTT, PT and INR, your coagulation panel is also important in this case, because if the patient has liver failure, they could have some impact on your PTT, PT and INR, as most of your clotting factors are in fact produced by your liver. Finally, you also will require another very important test, which is your EKG, because the patient has heart failure. So the EKG is basically going to tell you what is the electrical rhythm of your heart. So EKG is very important because you might be able to find out if the patient is having an acute MI. You will find out if the patient has left ventricular hypertrophy, maybe the patient has a left bundle branch block. Whatever the abnormal rhythm is, you are going to find out. And since the patient's heart rate is a 108 in this case, it might be that the patient is having atrial fibrillation, maybe an atrial flutter. Either way, EKG is very important. Pretty much all cases that you're going to be admitting. However, if it's a cardiac case, make sure you get an EKG. Alright. Now, because the patient is also short of breath, you want to find out how much oxygenation is present, right, in the patient's blood. You could get a pulse oximetry, which is completely fine. If it is more severe, you want to know what the oxygenation in the blood is. For that reason, at that point, you might want to get a VBG or an ABG, or else a pulse oximetry is completely fine. Alright, now all these tests you did as a basic workup, very good, perfectly fine. However, in order for you to get your perfect diagnosis of heart failure, what do you need? What is your gold standard test that is done even on board questions when they ask you? This is in fact your answer, and that is a transthoracic echo. Now this is what is going to tell you how your management is gonna be affected, and therefore all patients who come with a new onset heart failure, you must get a echocardiography. So now we are going to go into the most important and the most crucial part of your internship, which is your assessment and plan. This is where you're going to tell us what do you think the patient has and how you're going to manage. Now, based on everything you've done, you've already placed your orders, you know this patient most likely has heart failure, and in order for you to diagnose, what are you going to get? You're going to get an echo. So you are going to order an echo, and this basically determines where you're going to go with regards to your management. All right. However, doesn't matter what type of heart failure it is. If the patient has fluid overload, what is your gold standard treatment? What is your goal? As an intern, you need to know this. What is your goal? What are you going to treat the patient with to get the fluid out? Are you saying furosemide? You're absolutely correct. And basically in the hospital, you're going to be calling this Lasix. All right. So number one, you are going to be treating the patient with furosemide. Now, this is not a USMLE question for you, but rather you are an intern and therefore you need to know dosing. How much Lasix are you going to give? If you follow the guidelines, a simple rule of thumb as to calculate how much Lasix you want to give the patient is going to be 40 times the patient's creatinine. All right, if the patient has a creatinine of 2, you will give 80 of Lasix as the initial dose. Again, it's all comes to your discretion. You will give Lasix as of furosemide and you will see the response of the patient, and you can go up as much as you want. Okay, but the way to calculate initial dosing is 40 times creatinine if the patient is Lasix naive. If the patient has been on Lasix at home or furosemide at home, what you can do is 2.5 times the home dosing. So if the patient is furosemide on furosemide at home, you will do 2.5 times the patient's home dose. Alright, so Lasix is just one part of the story. However, in order for you to find out what's going on, you need to get an echo, as I already said. So you need to do the management and your test concurrently. So you get an echo on this patient, and all depends on the ejection fraction. If you have an EF which is greater than 50%, or you can have an EF between 40 to 50%, or you can have an EF which is going to be less than 40%. They all three are going to have different definitions. Reason is the management is a little different. If you look at a person with an EF greater than 50%, you're going to call this a heart failure with preserved ejection fraction. Whereas if you have an EF less than 40%, you are going to call this heart failure with reduced ejection fraction, HFrEF. This is your big HFrEF, heart failure with reduced ejection fraction. So what is this all about? 40 to 50, it is a gray zone, it is a gray area. Sometimes people refer to this area as mid-range heart failure. All right, it is not reduced heart failure. If you want to call it heart failure with reduced ejection fraction, your EF must be below 40%. Reason I bring this up is which of these three actually has medication that actually brings about mortality benefit. Where do you have guideline directed medical therapy for? It is only for heart failure with reduced ejection fraction. This is where all the drugs are actually going to improve mortality in the patient. If you look at a heart failure with preserved ejection fraction, you do not have any medication that actually has mortality benefit. Since we're talking about heart failure, most commonly most of you guys are going to encounter a case where you're going to have a patient with an EF between 40 to 50 or an EF less than 40%. What you're going to do is, once you get this echocardiogram and you have a diagnosis of 40 to 50 or below 40%, now you're going to start the patient on certain medications. So let's dive right into it. So when you look at it, the multiple groups that are present, group number one is going to be a beta blocker. There's only 3 beta blockers that actually have shown to have mortality benefit in the context of heart failure with reduced ejection fraction, and they are metoprolol succinate, which is a 24-hour acting drug. It is not your metoprolol tartrate, which is short acting. It is metoprolol succinate. All right, carvedilol, and then finally bisoprolol. These are the 3 beta blockers that actually have mortality benefit. Now if you see here, I have written down 200 milligrams of metoprolol succinate, carvedilol 25 milligrams BID or 50 milligrams BID if the patient's weight is greater than 85 kilograms, and finally bisoprolol 10 milligrams. These are quite high doses. You never start at a high dose. What I'm trying to say is these are the best doses, the best and the most optimal dose that are present to actually show mortality benefit. However, we cannot start at such a high dose to begin with. You'll start at a low dose and you'll keep up titrating and try to get to your target, but most times you won't even be able to reach the target. Reason is, when you start these medications, blood pressures can go down and there are all sorts of other things that could happen. So what you're trying to do is, with the beta blockers, you want to target a heart rate of 55 to 60. Another big question as an intern you must know, and you're going to be telling your senior resident or you're attending, oh, I want to increase the dose of the beta blocker. How often can you increase the dose of the beta blocker? Can you alter it daily? Absolutely not. It's a complete misconception that people have. You must increase the dose of beta blockers every once a week or once in 2 weeks. You cannot increase the dose of beta blocker on a daily basis. That is completely wrong. All right. Number 2, we will go into the next part. It is going to be your next group of medication, which is your ACE inhibitors, ARBs, and a new group that we have, which is ARNI, angiotensin receptor neprilysin inhibitor. If you look at your ACE inhibitors, ARBs, and ARNI, they all have mortality benefit. One important point I want to make is enalapril. If you see enalapril and if you're using it for management of hypertension, you'll normally do a once daily dosing. It is totally fine for hypertension. But if you ever want to treat a patient for heart failure, your enalapril dosing must be BID, not once daily. So that's an important point I want you to remember. If I asked you, in the combination between ACE, ARBs, and ARNI, which one is actually the best as of now, which gives us the most amount of mortality benefit promise, is in fact your group ARNI. Sacubitril valsartan is such a great drug. It actually has shown a lot of mortality benefit and improvement in cardiac function. Alright, another important question that I'd like to ask you guys is, you have beta blockers, you have your next group which is ACE, ARBs, and ARNI. Is each of them better by itself, or are they better as a combination? Combination is always better. Alright, beta blockers and one of these three always will work better if it is in combination. So you want to start both of them together but at a lower dose. So make sure you remember that. One more thing before you start ACE, ARBs, and ARNI, you must make sure the patient's creatinine is okay. If the patient has an acute kidney injury, a rise in creatinine, you know that these groups can actually affect the patient's kidney function, and therefore you must be cautious before you start it. Okay, so the first two drugs you must always start is a beta blocker or ACE, ARBs, and ARNI. Fine. Now you have the patient started on these two medications and you're giving the guy Lasix, and he's actually improving. He's making a lot of urine. He's producing a lot of urine. His daily weights are going down. You're monitoring his urine output. It looks great. And you're giving him a water or a fluid restriction to about 1 to 1.5 liters per day. These are the important steps of the management of acute exacerbation of heart failure. Alright, so now you already have your patient on a beta blocker and the next group ACE, ARBs, or ARNI. What other medication can you further add on? That's the big question. Alright, the next group you have is an aldosterone receptor blocker. The two drugs that you have is spironolactone and eplerenone. In order for you to be able to start these two medications, there are three criteria that you must always remember. Number one, creatinine. Creatinine in the male should not be greater than 2.5, and the female creatinine should be less than 2. Alright, so female less than 2, males less than 2.5. Also, the patient's potassium must be normal, because you know, if you're looking at these two medications, spironolactone and eplerenone, it causes hyperkalemia. Number three, the patient must follow up in a clinic within a week to get the patient's lab checked, because you want to monitor the potassium levels. Alright, so that's the next group. And the next group that you have is a hydralazine plus isosorbide dinitrate. Normally the dosing that goes for this medication is going to be TID, or Q8 hourly is the dosing for hydralazine plus isosorbide. Now, which population does this medication have mortality benefit? It is in an African American population, and the patient must have already been on the above mentioned drugs, and the patient must have NYHA class 3 to class 4 in symptoms. It is only then that you'll actually have mortality benefit while using hydralazine plus isosorbide dinitrate. And finally, you have another new group of drug which is known as ivabradine, which is not really proven to have mortality benefit. However, it does help the symptomatology of the patients with heart failure. How does ivabradine work? It is a sodium funny current blocker. For further information on it, check out my step 1 video which explains the exact mechanism action of ivabradine. So you've diagnosed your patient who came at 4 p.m. before you leave home, and you've diagnosed the patient with heart failure based on your echo finding. Just because you find out the patient has heart failure, your story does not end. You started the patient on guideline directed medical therapy, you gave the patient Lasix for symptomatic improvement, and you put the patient on fluid restriction, all and went perfect. However, anybody who's been diagnosed with a new onset heart failure must have a certain thing done. What is that? You must do something known as an ischemic workup, because one of the most common causes for an systolic heart failure is in fact coronary artery disease. So how are you going to determine what kind of ischemic workup you're going to do? It depends upon your TIMI score. The TIMI score is an age greater than 65, 3 or more risk factors for coronary artery disease, aspirin used within the past 1 week, EKG changes, specifically ST segment changes, elevated troponin, or if the patient has a known more than 50% stenosis of the coronary arteries, and finally chest pain, which is a classic story within the past 24 hours. As you see, there are 7 points. If you have 1 to 2 points, it is called a mild risk, whereas if it's 3 to 4 points, it is an intermediate risk, whereas 5 to 7 is high risk for coronary artery disease. So a mild risk can ideally normally go for some form of stress test, and the stress test, again, it could be an exercise stress test, it could be a dobutamine echo, or it could be a nuclear thallium scan. Okay, the choice is yours. However, if it is an intermediate to a high risk, now this patient must go for a PCI, which is a coronary angiogram, to identify which vessel is blocked, because once you fix the vessel, the patient's heart function can improve. All right, so that is very important for you guys to know. You guys have managed your heart failure patient perfectly well. All right, so let's go over our checklist. New onset heart failure. You got your echocardiography and you diagnosed the person with the heart failure. You did your ischemic workup based on following TIMI score, and you gave your patient Lasix and got the patient very well diuresed, and then you also started the patient on guideline directed medical therapy. Another important question that always comes up is the fact that about AICD versus a biventricular pacemaker. Are you going to place all these devices at the time of diagnosis? Absolutely not. The basic guideline is you will try guideline directed medical therapy for at least 3 months. At least 3 months you'll try guideline directed medical therapy. After 3 months you will repeat your echo, and if your echo is going to show a decreased ejection fraction less than 35%, now the patient is going to become a candidate for AICD versus biventricular pacemaker placement. What determines which one is which is if you have a widened QRS, a QRS greater than 150, now this patient will get a biventricular pacemaker device, whereas a patient with just a reduced ejection fraction but your QRS complex is normal will get an AICD placement. The reason we are placing these devices is when your heart function is so low, the patient is more prone for arrhythmias and as a result sudden death. So that is the reason you're going to do, and the reason you want to give it some time before you place this device is because with your guideline directed medical therapy, the patient's heart function can actually very well improve, and therefore by 3 months you might not need to even place the device at all. So that is the reason for this 3-month period. Now in between 3-month period, there are certain devices which is not part of guidelines, such as placement of an external defibrillator known as a life vest. I won't get into this. I will leave this for you to discuss with the cardiologist in the hospital, and under their discretion they can decide if they want to place the patient on any of these devices or not. But based on guidelines, for the first 3 months you do no placement of any form of the external defibrillator. You'll repeat the echo at 3-month period and go from there. Now finally, before we conclude our lecture for today, what are the 3 important steps that is going to prevent your patient from coming back to the hospital within a week, within 2 weeks? You want to prevent the patient from having recurrent episodes. So to decrease your readmission rates, there's 3 things that you must do. Number 1, you must make sure you bring the patient to his dry weight as much as possible. So you're going to give so much furosemide to this patient and monitor him slow. Take your time and make sure the patient is dried out before he leaves the hospital. Number 2, make sure you started the patient on all the necessary guideline directed medical therapy. He must be optimized on his medications. Number 3, you must give this guy an appointment within a week to go and get his labs checked out and to follow up with the doctor. You do these 3 maneuvers and these 3 methods, you will make sure that the patient does not come back to the hospital within 1 week. So this concludes our video on heart failure, and I hope you guys enjoyed this video. Please subscribe, and I'll see you guys on the next video, which is gonna be on management of strokes for an intern.